Okay, great. We're going to go ahead and get started here. Thank you, everyone, for joining the Nearman Practice Management Tuesday Evening Study Group. Before we get rolling here, just a couple quick housekeeping items for those of you that just joined the line. You may have noticed that your lines will be muted for the duration of the presentation, but if you do have any questions, please submit those in the chat box or the Q&A box that you'll find on the bottom of the meeting window in the meeting controls. So with that, we're going to go ahead and get Dr. Patel to share his screen here, and we'll get the recording started and we'll get rolling here.
Okay.
And so again, thank you everybody for joining this evening. The topic we're going to be covering tonight is TMD for the dental sleep medicine practice. What do I need to know? So we have, for those of you that have not met him or heard him speak just yet, we have a wonderful presenter, Dr. Mayoor Patel, who is not only the clinical director of education for us here at Nearman Practice Management, but also just an impressive list of credentials, including diplomates of different sleep, almost every TMD and sleep organization out there, like the American Academy of Dental Sleep Medicine, craniofacial pain, and countless others. So he's a perfect speaker for this topic, and thank you, Dr. Patel, for taking the time to educate this evening. We're going to be talking about basic understanding of the TM joint, the correlation of the TM joint and sleep disorders, common issues that may arise from oral appliance therapy, and how to minimize TMD issues. So again, thank you, Dr. Patel, and we're so excited to hear your talk.
Thank you, Courtney, and thank you everybody else for taking the time out to listen to this webinar. I trust you'll probably walk away with one or two pearls, and I think that'll be an aha moment for most of us, and therefore be worth you a while listening to this webinar. I'm going to start off by just talking about the temporalmandibular joint. I won't labor it, but I just want to kind of point out a couple of highlight things which will come back in discussion. So as we all are aware, the joint is encompassed with a lot of different sections. We have the superior joint space, we've got the inferior joint space, we also have the disc. And if we look at that disc, that thick band that you see that's about 12 o'clock right on top of the condyle is the posterior band. And when that band is healthy and the disc has not been violated by any means, it prevents itself from slipping between the articular eminence and the condyle. In other words, if you have a healthy disc, you probably won't run into any issues as far as TMD-related internal derangement aspects of treating these patients with oral appliances. But an interesting thing also to bring to your attention is if you look at those pterygoid muscles, you have the superior head and you also have the inferior head. The inferior head primarily inserts into the fovea of the condyle, but the superior head inserts both into the disc and portions of the condylar head. And there's various anatomical descriptions about what aspect and what percentage inserts into the disc versus the condyle. But bottom line is there is definitely some muscles that attach to the disc, and it's of value to understand that now as we discuss this a little bit further down the road. So with that in mind, I just want you to also be aware of some of those muscles that support the jaw. Of course, the big green one is your masseter muscles that we all deal with. And as a result of it,
powerful muscle.
As a result of it, that's one of the muscles that we see that notoriously plays a role when it comes to clenching, grinding, and gritting, especially in some of these patients that have a tendency of bruxing. As you might see, right towards the back where the condylar head is, you'll see some fibers in the masseter that run more perpendicular. That's your deep masseter muscle. It's kind of tucked way behind the superficial. That muscle, when it's affected, has a tendency of causing a lot of ear-related symptoms. And we'll talk about some of these ear-related symptoms that may develop as a result of wearing the oral appliance. And then, of course, the muscle that's directly above it is your temporalis muscle. Once again, it comes together into a tendon and inserts into the corner process. So with this understanding of where we are in regards to these muscles, you can also see that little anatomical video running on the opposite side demonstrate not just the masseter muscles, but also portions of the medial pterygoid. And there again, here's your medial pterygoid. And if we look at the medial pterygoid, starts off on the lateral plate of the pterygoids on the medial aspect, and the lateral pterygoids originates on the lateral aspect of the pterygoid plate, inserting into the condylar head. So just kind of bringing back and kind of getting everybody oriented with where we are and what it is exactly that we are trying to get to. You'll see that the lateral pterygoid, when you dissect away the zygomatic arch, you have this tendency of demonstrating that it's kind of deep-seated, right? There's an angle to it. It goes more medially, which is where the pterygoid plate is. So that being said, it's a very difficult muscle to palpate using a finger back in the buccal vestibule right behind the retromolar area. The way you palpate this is indirectly by using forces. In other words, having the patient open against resistance or protrude against resistance. And if they evoke pain in the jaw area, then you're thinking about the lateral pterygoid. As mentioned, it's a very difficult muscle to get your finger back there. And in those of us that have in the past, not knowing any better, everybody seems to have a tender lateral pterygoid because of its location. All right, now, how do we avoid some of these issues? You know, it's fundamental, but it is fundamental that we need to document the presence of any muscle or joint issues prior to the delivery of an oral appliance, or even prior to having the discussion about oral appliance therapy for your patients. Now, if anything, if you can home into your skills and develop skill sets to understand the documentation process, but more importantly, the examination process and all aspects of it, the joint, the capsule, the muscles, the tendons, and also the ligaments. If we can find something going into the case that demonstrates there are some issues, then maybe it's time to have a discussion on what we may need to do prior to fitting them with the device. Or in some instances, you can use the device, but you may not want to be aggressively protruding the mandible in the early stages. So documentation is very important. But your physical example is looking for jaw function, basically range of motion. Is there any limitations there? Is there any joint sounds that you might hear? Palpating the joints to demonstrate if there's any tenderness associated with it, along with not just the masturatory muscles, but also the cervical muscles, to get a good global perspective of what this head is like prior to initiating treatment. Now, if we follow the literature for a moment in time, you'll find that there's a frequency of temporary side effects that do develop in patients with oral appliance therapy. And depending on, once again, the publication, it's anywhere between 6 to 86%. And I will have a list of references for you to go back and look at. But the most common one that you might bump into is TMJ pain. Pain that initiates itself maybe a couple days after getting the oral appliance, or maybe a couple of weeks after getting the device. And we'll talk about what might that be. Myofascial pain, where there's a muscular component associated with this pain. When I eat, it hurts. When I open my mouth, it hurts. When my jaw's at rest, nothing happens. If I bite down too hard on foods, it feels like I have a toothache, a myofascial component that might be associated with it. Some cases, tooth pain. When you have tooth pain, though, primarily, it's probably the device is a little too tight on it, or there was a distorted impression, or somewhere along those lines, there's excessive pressure on the tooth. And by adjusting the area where that tooth might be in contact with the device, more times than not, it rectifies that issue. Now, funny enough that salivation is placed in this category, but in reality, it's a temporary problem. It's really not a side effect. It's your body's response to thinking that this is a food particle or food itself, and as a result, excretes more saliva. What you'll find with salivation is within a few days, in some cases a week or so, the salivation rate does decrease, and it does not become a nuisance as the individual gets acclimated with the oral appliance. Joint sounds. You know, and we'll spend some time talking about joint sounds. This is an example where you've examined your patient, no clicking, no popping. You fit them with a device, off they go, they're happy. 3, 4, 5 weeks into this, they start having jaw that's clicking. They never clicked before. All right, so the question is, why did it start clicking? And we need to understand this a little bit better. It's not possibly the reason for your device causing it, but there probably is another explanation for why that happened. Dry mouth, there again, excessive vertical on oral appliances. If the nasal passage is not working effectively, these may be reasons why dry mouth may exist. So trying to get the etiology of why this individual is having dry mouth might solve that problem itself. Gum irritation will fall in the same category as tooth pain, just relieving the area, and that typically will take care of itself. But the one temporary side effect that we do deal with on a day-to-day basis is this morning occlusal change that happens to removing the oral appliance. And we'll once again spend a little bit of time laboring this occlusal change, because that's something we need to make sure we revert or reverse upon awakening, so it does not progressively become an issue for the individual. And as we all know, occlusal changes are likely to happen the longer a person wears an oral appliance. And there again, in your informed consent, all this information is disclosed. So let's look at a couple things in regards to it. So the prevalence estimated that between 10 to 30% of patients using an oral appliance for sleep apnea management will develop TMD symptoms. Now, the question I may pose is, could it be that they had symptoms already and that 10 to 30% of patients may have now exaggerated their symptoms? In other words, they're more aware that they have a problem now than may have been there prior. So keep that in the back of your mind. And we do know that irreversible bite change does happen about 10% of the time. And if you take a history on these individuals, you'll find that they start off doing what you ask them to do, but then they realize that there's no difference in their bite, so they stop doing those morning activities. And as time progresses, you start seeing a more protrusive change in the mandible, going from maybe a class 1 relationship to more of a class 3. And those that are in class 2, reverting to more of a class 1 type of a molar relationship. But there again, an irreversible bite change. Now, the word irreversible means we cannot get it back, but in some cases, you are able to get this back, and I'll show you that at the end of this presentation. So to kind of show you the prevalence, if you really look at it from the perspective of apneics themselves, and here's a study done in Brazil. It was interesting because that 87 patients that were already diagnosed with having apnea, walking into a dental office ready to get an oral appliance. The practitioners examine these patients like you should all do, and what they determined is almost half of them had some prevalence of TMD disorder. So if you think about this for a minute, if more than half of them already had a TMD problem, then we need to kind of take this into consideration before we fit them with an appliance, or factor in what we might need to do to minimize escalation of these symptoms or flaring of these symptoms. But the fact that the study demonstrated that these apneics, positively tested, had at least some level of TMD symptom is very important to keep in the back of our mind. Now, how do you go through this process? Let's make some assumptions. Appliance is given, patient's gone, patient's happy, patient calls you, they come back in, and now you need to figure out what's wrong with them. And the way you start figuring out what's wrong with them is you don't just jump to conclusions based on what the patient says. Oh, I was wearing a device and the next morning I had this issue. And we have a tendency of jumping the gun and coming up with a quick solution. What you need to do is get a detailed history of what exactly happened to give you a better understanding of what you could possibly do to assist them with their symptoms. So the whole process is an interview. And we'll spend some time laboring these various aspects as far as gathering information to get a better understanding of what they have. The first thing is location, location, location. Where is your symptoms? Where is your pain? You want them to point to it. Because when they point to it, it's a little bit more specific as opposed to putting their hand up across an area that hurts. As you can see in this picture, where the finger is being pointed at, it seems like it's more jaw. But if we look to the first picture that has the circle with the cross in it, it may be jaw, it may be muscle, it may be both. It's very hard to differentiate what this individual has. So location, by using one finger to describe or to demonstrate where that pain is important itself. Understand the circumstances that made this pain worse. So what happened? Did it start off gradually? Is it worse in the mornings? Is it worse in the evenings? Is it worse when you eat? What exactly has to happen for you to notice this discomfort? And this has some value as well when it comes down to pinning down what they may potentially have. How bad is this pain? I will share this with you. When we ask somebody how bad the pain is, in reality, all we're asking is, all right, you have pain as far as you are concerned. In your mind, 0 being no pain, 10 being the worst pain you've ever had, how bad's your pain? The reason for understanding this is the patient's perspective of how bad this pain is, not necessarily saying how severe the condition might be, but also it gives you numerical values. So therefore, if you were to do something chairside, are you able to improve their pain? And what you're looking for is at least a 2-point reduction on a numerical pain rating scale. So if they rated the pain as an 8, and you happen to do maybe a massage or inject the muscle or do something to this muscle, and from an 8 it goes down to a 5, fantastic. That means what you're doing is on the right path, and it might be muscular by nature. But if you do something to the muscle and the pain's still present, nothing happens, then it's not muscle. More than likely, it's something else that you've kind of overlooked. So the intensity kind of just gives you a perspective of what is it that you have, and after I render some form of treatment, what actually happens to you. So just some things, once again, to keep in the back of your mind in regards to it. Now, if you look at frequency, how does the pain come? Does it come in clusters? Does it disappear for a period of time? Is it continuous in nature? And then if it does come, how long does it last? Is it a few minutes upon awakening? Is it hours upon awakening? And then of course, duration, days, weeks, months. Hopefully these patients have come in within days, not weeks and months. And is the daily duration rated as continuous or intermittent based on your history? So frequency, duration, very important once again, because various types of pain have a frequency pattern and a duration aspect associated with it. What triggers it? So you take the device out, what makes the pain worse? Is it eating? Is it opening wide? Is the mere fact that when you wear the device, you have pain, but if you discontinue wearing the device, you don't have pain? There again, getting information. Have you tried anything to alleviate it? Heat, ice, Advil, Motrin, what have you done for it? And based on what they say, it'll give you an idea. For instance, if they say that anti-inflammatories does help, then what you're looking for is an inflammatory process that's probably existing, where you think of maybe capsulitis, tendinitis, or myositis, as an example. If massage helps, then you're thinking of muscular by nature. If heat helps, you're thinking muscular by nature. And the mere fact that they're discontinuing the appliance, it could be both muscle, or it could be both joint, or a combination of both. So there again, alleviating factors can also point you in the right direction based on how they describe it. Anything happened, maybe during the duration of wearing this device? For example, were you intubated? Did you have some procedure done that your mouth was open for a very long period of time? You know, you're trying to get an understanding, is there anything that happened during that time period that could explain this? Also, what are you taking for this pain? Because by them suggesting or disclosing what they're taking, it'll give you an idea of what might be happening. You notice I put herbal and over the counter, and you got to be cautious here because a lot of times people will disclose prescriptions, but they'll never disclose anything that might be natural or something that might be holistic in nature. So what I have a tendency of doing is always asking the question. Now, if I take CoQ10, I take magnesium mineral for myself, I take fish oil, do you do anything of this for your own health? When they realize you are like one of them, they're more likely to disclose all the herbals or over-the-counter medications that are not disclosed. And you want to know this, because if you don't know this, by the time you prescribe some of your medications, you may have some interactions with it. So patients may think that because it's natural, it's safe, but not realizing that, nope, there's got to be something else associated with it. So keep that in the back of your mind. Very, very important that we actually have that conversation with them. Now, how else can this help you? I'm taking anti-inflammatories, inflammatory, right? If we went from a herbal perspective, I take magnesium, and it makes me feel better, makes my pain feel better. So if you know what magnesium property is, it has a muscle relaxant component associated with it, and it also has a pain modulating. So the question might be, could it be muscular by nature? I use Bengay, and it makes the pain better. So they're using heat. So they're, again, extrapolating with what they're doing medicinally wise to get an idea of what might be happening with them. You know, even though this is a sleep history that we're going to take, we want to kind of get an understanding, have we addressed any of the issues associated with sleep? Can it be that maybe they're still snoring, maybe they're still tired, but as a result of wearing this device, they are still symptomatic where they get jaw pain or muscle pain. And maybe they are still having jaw and muscle pain because they're still possibly clenching or grinding, potentially, in some cases, in an effort to possibly open up the airway. So there again, have we addressed maybe some of the sleep history aspects that may explain the influence of pain that they may have? Any parafunctional activity that you need to be aware of, because they may wear the device at night, but during the day they gum chew, they nail bite, or they clench. Well, these things itself can hinder, because if they do this during the day, 16 hours when they're awake, 8 hours when they sleep, they could cause enough of an aggravation that when the device goes in, it flares things up. So keep that in the back of your mind that we need to take that into consideration. Now, the exam, what you need to do. I will suggest you all need to calibrate yourself. The best way to calibrate yourself is a food scale. Make sure you understand what it takes to put 2.2 pounds of pressure, because if you know how much force that takes, it means that when you palpate muscles, you want to be consistent. You don't want to have fluctuations in how hard you push. And with the temporal mandibular joint, it's about half that strength. So you want to calibrate yourself so you have equality when you're examining these individuals. Now, the intention for palpating, in all fairness, is to try to find where the pain is. You're just trying to elicit referred pain or elicit the familiar pain that they actually have. You can also reproduce some of the pain. When they say eating hurts or chewing hurts, well, then have them clench and see, does it aggravate it? Manipulate the jaw if you feel that it's necessary, that causes or provokes pain. And you want to get a feel for what is it that they do that provokes the pain. And I want you to be able to try and reproduce the pain, whether you do it manually or functionally by having them bite on cotton rolls, tongue depressors, or purely by you palpating. Because if you can reproduce the pain in these areas, then you know what you're dealing with. Joint palpations, a couple things you're looking for. Is it tender? Is there pain? Is there swelling? Is there patterns of movements that might be disoriented? For example, they were opening straight the day of delivery, but now they seem to have a slight deviation or a deflection to one side. Questions will then be posed. Why? Palpate. If there's joint sounds, when is it? Is it early? Is it middle? Is it late? Does it happen both on the opening stroke and the closing stroke? Or do we have any other fancy joint sounds such as crepitus, things of that sort? So when we look at sounds themselves, you want to be very clear with this. A click is a very distinctive sound. Patients may say, "Doc, I click," but when you listen to them, you can't hear it. There can be other reasons why someone generates sound, but if it's a disc that has slipped, it's extremely distinctive. It's a nice, solid click that is reproducible every time they open. Crepitus, on the other hand, is when they open, it sounds like a crunching or a grating sound. The best way to describe it is if you took two rocks and rubbed them against each other, that sound you hear is crepitus. What crepitus is synonymous with is more than likely osteoarthritis or osteoarthrosis in the joint. Then the other thing is an eminence click, and this is when patients say, "I only click when I open wide or when I yawn." Basically, what that suggests is they're jumping off the eminence. That's kind of normal. It's not pathological, but it can also lead them at some point of possibly having a lock open situation. So if you have an eminence click, then the idea here is to educate them not to hyperextend, and just as importantly, trying to keep within their range of movement or motion so they don't create that click, therefore minimizing the possible risk of having an open lock. Now, deflection, the first picture that you see on your left, when the person opens, they go to one side itself. So if you look at that patient, you'll see that they go off to their left. Them going off to the left would suggest that that left jaw joint, that disc is not moving like it needs to. In other words, it's stuck. And as a result, they're trying to open, right side's moving normal, left side's not. Because the right side's still going through its progressive opening, it's going to kick off to the left. Deviation, on the other hand, is they open and they go to one side and then they go back to midline and they continuously open. In other words, they start off straight, go off to one side, and then they finish off straight. Deviation is, what you might find with deviation is at the peak of that turn, there'll be a click, suggesting there was a disc that slipped, which was the initial part of them getting kicked off to one side. When they click, it would suggest it reduced, and because it now reduced, they're able to gain and open in a much more direct, straight pattern. So deflection and deviation will also give you some clues associated with this. I will share that with deflection, you'll never hear a joint sound, but there's always a history of prior clicking that used to exist that kind of disappeared at some point in time. And the history is very important when it comes to deflection. But just so that you all understand this a little bit clearly, I'm just going to go over a couple things here. If we talk about disc displacement with reduction, what it means is the disc is slipped, but when they open, we hear a click, which means it's able to reduce. So there's a reproducible joint sound that occurs on opening more so than on closing, but in some instances, you could have a closing aspect. Soft tissue imaging would demonstrate that a disc is slipped forward and improves when the person opens the mouth, but that requires an MRI. Not always mandated, but there again, if you're not certain, then the MRI is the only way to confirm this. But when you take your regular x-rays, you're not going to see extensive degenerative bony changes. So it's going to be very hard to extrapolate from a Panorex and or say a tomogram of the temporalmandibular joint that they have a disc that's slipped. Since the disc is soft tissue, the MRI is the only way to make it happen. But what you may also find with these patients, there may be pain. And there may be pain precipitated by specific jaw movements. So when the jaw is at rest, no pain. When the jaw starts moving, there may be pain. But you'll also be surprised that not always people with a disc displacement have pain. So just keep it in your back of the mind. It's not necessary that pain needs to be there. We talked about that deviation during opening. Movement coincides with the click. So there's definitely a pattern associated with it. Interesting enough, no restrictions in range of motion. So they can open normally, go laterals normally, protrusive normally, no issues with that. And maybe at times they may have episodic catching that may happen, but itself reduces when they move or open their mouths. In other words, it's reducing, and as time progresses, it's going towards its next phase, and now you're getting momentary situations where it actually is catching. But there again, they're able to manipulate the jaw by moving it from one side to the other and continuously being able to open. So not major concern, but there again associated with a disc displacement with reduction. And if we look at these videos here, the video on the left is a normal joint. As you can see, the big thick band that I described earlier sits at the 12 o'clock position. So as a person opens, you see that big thick band stays behind the condyle as the condyle goes down the articular eminence and moves forward. On the image on the right, what you see is when the teeth are together, the condyle is where it needs to be, but the posterior band's anterior. And when they open, you hear a click. When it goes back in place is when you hear the click. And if you see it, once they have opened, the positioning of that tissue is almost identical to the positioning of tissue in the normal joint. In other words, you have tissue between the articular eminence and the condyle. All right, so when they open, there's a click, but when they close their mouth, the disc slips out. So in essence, when the teeth are touching, they have a disc that's actually slipped, and the only time it goes in is when they actually open. Now, what can happen in some instances, you go from a disc that was clicking to one day where it stops clicking. And what you're going to find initially is limited opening, all right, with a sudden onset. In other words, I went to bed, I woke up the next day, I couldn't open my mouth. Or I was eating something hard, chewy, sticky, and at that point I heard a sound, and from that point on, I can't open any wider. There's always a history associated with it. There's always going to be deflection to the affected side of an opening, as described in the video, where the jaw or the chin point goes to one side, whether it's the left or the right. There will definitely be marked limited lateral movement to the contralateral side. So if we picture this, if my left disc is slipped forward, when I open, I'm going to deflect to the left. When I do my right lateral excursion, I'm going to be limited. But I can have a normal range when I do my left lateral excursion. And protrusion may or may not be limited, but the key here is limited range of motion, deflection, and contralateral measurement being not adequate compared to the ipsilateral side as far as where the disc might be slipped. Now, only way to know for sure, soft tissue imaging. Only way you can pull that off is an MRI. Once again, the history many a times can give you an idea what's wrong with them. It's when you have uncertainty or things just don't add up, maybe an MRI will be warranted. In some cases, pain perceptuated by forced mouth opening, which makes sense. If the tissue is anteriorly displaced, then everything behind the disc is retrodiscal tissue, which is highly innervated. So now if you open and you have them push against a disc that slipped, you can aggravate that joint discomfort. This is very important. History of clicking that ceased when this locking happened. In other words, there was a history of clicking that happened, and as soon as I couldn't open my mouth, there's no more clicking. Very, very important. And I'm going to home into this when I show you a progression of how disc displacement without reduction may look like clinically, and throw a curveball at you thinking that the joint is actually healthy and normal. Pain, when palpating the affected joint, definitely going to have some pain there. In the early stages, in the example I used earlier, if the left disc was slipped forward, I would have hyperocclusion on the side that the disc slipped. Okay, because what you're going to get is the disc goes forward, then your condylar head is going to slightly sit more superiorly, and as a response, you get hyperocclusion on the ipsilateral side. In the early stages, you're not going to see any hard tissue imaging changes, okay? But if this condition stays untreated and enough time has lapsed, you may then pick up on some hard tissue bony changes. The chronic situation, once again, history of sudden onset, soft tissue imaging, that soft tissue displaced without reduction, pain reduces from acute state. When it slips, it hurts. When it stays slipped for a period of time, pain actually reduces. History of clicking that ceased when locking, consistent with the previous one. Maybe at this point now we have crepitation with mandibular movement because it's been chronic enough where now we're generating a sound that's more like a rubbing friction between bone and bone. And what you also will find is there's a gradual resolution of limited mouth opening. So what they may have opened at 24 millimeters 2 years ago, they come into your office today, they open to 42. If you looked at today and they open to 42, you may go with the consensus, joints are healthy. But if you ask the question, was there ever a history of a clicking, popping joint in the past? And they say yes to it. Then you need to follow up and say, well, then was there ever a point in time that even though you had the clicking and no pain, you had limited opening for a moment and maybe some discomfort that progressively got better? And if they say yes to that part, then what you're dealing with in your chair is a normal opening range, but a disc that now has been anteriorly displaced significantly. And there's a reason I'm homing into this, because it itself can cause you to have a nightmare as we go down this progression of slide sets. And just to show you what that looks like, once again, normal on your left, you've got on the right the anterior disc displacement without reduction. So you'll see that the disc is just anterior to the condyle. Here the person is teeth together as they open, there's no click, there's no pop, they're able to give you a decent full range, but the meniscus or the tissue, the disc, is anteriorly disposed, okay? So that's disc displacement without reduction. So let's look at this example right here. Person opens, there's a click, and there's a little bit of a deviation to the right, and they open at 42 millimeters. They go off to their right lateral excursion of 9, and they go off to the left lateral excursion of a 10. Now, even though I can't ask you these questions directly, mentally, I want you to get an idea of what you think may have happened. And what actually has happened is they have a right disc displacement with reduction. So this kind of gives you an idea based on what you're seeing that they have a situation that's playing out. But let's look at this example here then. All right, they go off to the left. So they're deflecting to the left and they only open 27 millimeters. The right excursion is only 4, but the left excursion is now 10. Once again, if you were looking at this, you should be able to come up with an idea of what might be going on. And what this demonstrates is a left disc displacement without reduction. So let's just check that again. They deflected to the left, which is one of the situations that you need with disc displacement without reduction. Limited opening, consistent with that finding. Contralateral lateral movement, in other words, moving to the right, it's going to be limited, as you can see here. But the movement to the affected side, to the left side, laterally speaking, is somewhat normal. So here again, with this kind of a combination, it gives you a consensus that you got left disc displacement without reduction. Now this happens also. This is your day of delivery, right? You get a picture, you fit them with the device, and time has gone on, and they now present themselves with a situation like this, where one side, the teeth are not touching. Interesting. So there's a couple of situations that may have happened, and there's a couple of things that you might think may have happened. It could be a muscular component that's resulting into the fact that this disc is, sorry, this bite is not fitting correctly. What we could look at is maybe a left lateral pterygoid muscle spasm. Could it also be that maybe something is now occupying space that was not occupying space, therefore causing a gap between the teeth? That's a possibility. But sometimes we forget that could it be that the opposite joint, okay, not the left, but the right joint, maybe is arthritic and it's breaking down. And as a result, the contralateral side, you'll see a posterior open bite, as demonstrated here. So you got to kind of, in the back of your mind, have like a differential diagnosis going on. What could this possibly be? And then prove that by doing an examination and, of course, the interview that's associated with this. So let's look at a normal, healthy, functioning joint. You've got the fossa, you've got the blue, which is the disc, and you've got the condyle. All right, everybody's happy. The big, thickest part of the disc is sitting at the 12 o'clock position, and the condyle is more anterior superiorly, the new definition of centric relation, of course. And when the person opens, the disc goes with it. They go down the articular eminence, no issues, right? No clicking, no popping. Everything seems to be fantastic. But then we have disc displacement with reduction. So what that means is when the teeth are touching, the disc is now, instead of at 12 o'clock, the posterior band, it's more at 3 o'clock. And when they open, it orients itself what normal looks like. So this is where you'll have that click when the tissue goes back in place, and on opening, it looks perfectly normal as far as the relationship of the disc to the condyle to the articulating fossa. Disc displacement without reduction, all right, the disc is anteriorly displaced as pictured on the left, but when they open, it's still anteriorly displaced. All right, so keep that in mind as well. So what happens in situations when you have a unilateral posterior open bite? A situation where you can see that happens after some time period of wearing a device. And what we're going to do here is explore the possibilities associated with this. Well, the one thing I want you to be aware of is this situation right here. Could it be that the person had a disc that was displaced? In other words, it was already slipped forward. And as a result of wearing a device, now the tissue's gone back in place. And now because the tissue's gone back in place, they're going to have hypoocclusion on the side that the tissue went back in place. But another way to also look at this is this progression process of when someone has a locked jaw. In other words, they had a clicking joint that happened at one point, and then they woke up one morning and they just could not open wide. So here you have someone that has limited opening, and what you see is that the joint doesn't move as much. But when you give this stuff time, and you let time take its toll, you'll see that there's deflection on the first one, there's deflection on the second one, and you'll see that the joint's now starting to move a little bit. And then you start seeing almost normalization, opening, very little deflection, range of motion improving, condyles moving down the eminence, even better. But guess what? At the expense of the disc. And now you have a situation where the person looks like they're opening normal, opens pretty wide, but now they've really displaced the disc anteriorly. The far picture on the right are the ones that you may go off with the understanding that they don't have a problem because everything looks normal. They got a straight opening path. They don't have any deviation that's significant enough for you to draw your attention, and the lateral movements are normal. But if this situation is that the fact that they, in this scenario, because there's a disc that had displaced many years back, and we never asked the question, when we fit them with the device, we may run into some issues, right? And the issue we may run into is this right here. I did not have a problem. I got your appliance. Now my jaw started to pop. I'm sure you've heard this before. And what happens in that situation is they had a disc that was displaced, just never got identified. Because we put an oral appliance in the mouth, what we did is almost what we would do with splint therapy when we're trying to recapture a disc in some instances. When you wear a device that has some level of vertical, you'll see that the condyle will go a little bit more inferiorly, opening up the superior joint aspect as far as space is concerned. There again, creating a very versatile area where the tissue may just slide back in place, so that now when they put their teeth together, they've got that slight posterior open bite as described in this picture. Now, if the tissue does not go back in place, let's just take that assumption, then what would happen is, let me rephrase what I'm trying to say, excuse me. Disc is entry displaced, they wear the oral appliance. Disc goes back in place. Take the oral appliance out, disc slips back out. Now, without the appliance, they open. Disc is now going back in. So now they're getting something that was non-reducing that's reducing. This is where they're getting the click or the pop. Never had it before. Now it's clicking and popping. In actual reality, what you've done is you've done them a favor. You've actually taken something that was not reducing and now allowing it to reduce. From the patient's perspective, you've messed them up. So just keep this in the back of your mind that asking questions prior to fitting a device can prevent some of these situations from occurring. Other things that may happen when you have an oral appliance, specifically managing apnea, is jaw pain. A lot of times unilateral jaw pain has some relevance here. So with unilateral jaw pain, you need to palpate the joint capsule and kind of get a sense of what's going on. And what you'll find is if you push on that capsule and you are able to reproduce that pain, then you know you're dealing with a capsulitis. And it's very difficult to differentiate capsulitis from synovitis. So there's an inflammatory process taking place within that joint. And in this state of condition, if you were to get an imaging, specifically a hard tissue imaging, you're not going to see any bony changes specifically associated with this. It's going to be more of your history and your exam to nail them on a diagnosis of capsulitis, especially for the fact that they point to that area where the pain might be. Now, what might be some of the causes for it? Well, one thing could be that at delivery, the midlines were slightly off. In other words, maybe their teeth midline were on, you took your bite, they were off to the right, send it off to the lab makes it, sends it back to you, deliver the device, jaw's off to the right. A few days into this, pain on the right side, specifically the jaw. Another reason could be that their posterior contacts are maybe heavy. In other words, you didn't check it effectively, they go to bed, they're clamping on one side, the side that they're clamping on is causing them to have pain. Adjust the occlusion, more times they'll take care of it. When I mean adjust the occlusion, I'm making reference to the occlusion on the appliance, not their teeth at that point. History, I didn't have any problems with your device. Week 1 was great, week 2 was great, week 3 was great, but week 4, it started hurting my jaw. All right, what happened between week 1 and 2? Well, I advanced it. What happened between 2 and 3? I advanced it. What happened between 3 and 4? I advanced it, and then I noticed pain. Could it be that maybe they've taken that jaw beyond their, I guess, physiological range, therefore now it's eliciting discomfort? In that cases, if that history describes it as due to advancing, then back them back, and that should take care of it. Now, to treat capsulitis, it's pretty much no different than any itis. Avoid chewing hard foods, smaller bites, don't have raw veggies, steam it so that you break down the fibers, it's easy to eat. Maybe defer from eating salads initially. If you're chewing gum, cut that out. Apply moist heat to the area 2 to 3 times per day for about 5 minutes at a time. You can also adjunct this with some anti-inflammatories if you see the need for it. But there again, get an idea of what might have happened. Was it due to the fact of advancing too much? Was it due to the fact that maybe they need to go forward, but as a result of going forward, they're having discomfort? So we may need to explore the possibility of maybe now giving them vertical on the appliance because it's still symptomatic. Therefore, you don't aggravate the joint. So in some cases, that might come into play. And once again, as mentioned, anti-inflammatories, whatever your favorite anti-inflammatory might be, maybe put them on a dose regimen for it for about 5 to 7 days and see if we can nip down the inflammatory process associated with it. Every now and then you get unilateral temporal pain wearing a device. There's many reasons why that might happen. One in particular might just be the fact that, they're hitting heavy on that side, the left side, as far as muscle is concerned. But another reason for temporal pain might just be the joint itself. When the joint is affected, it's not uncommon for the joining muscles to also hurt. In other words, even though they may have a muscular type pain, you palpate the muscle, you can't reproduce the pain, but you palpate the capsule of the joint and the pain in the temporal area now increases, or the pain with a feeling increases. But when you palpated that area specifically, nothing happened. So keep this in the back of your mind that unilateral pain can be a little bit tricky, but something to just be aware of. And we'll spend a little bit more time on it here in a minute. So how do we differentiate? Is it jaw, is it muscle? So here's an example. 2 cotton rolls, right side, left side, have the patient bite down as hard as they can. Where does it hurt? Points to the left. Okay, cotton roll on the right side, any pain? No. Cotton roll on the left side, any pain? Yes, right in that general area. So this little analogy will give you an idea that they're dealing with a left side master muscle involvement. All right, I'll let you play with the second one. Use your mental powers to kind of come up with this answer, and I'll share the answer. Biting on both sides, pain on the left. Okay, biting on the right, pain on the left. Biting on the left, pain on the left. Interesting one, isn't it? So let's look at this again. What you got here is left muscle, but when they bite on the contralateral side, in other words, when they bite on the right side, what happens is the condyle on the right can't completely seat, but the condyle on the left can because nothing's preventing it from not seating. So when they bite on the right, you got the elevator muscles firing on both sides, but it seats the condyle a little bit more than the right does, and as a result, if there's pain or inflammation in the joint, they'll have pain. And this is exactly the pattern that they'll describe. So this gives you an idea that they have a muscular component and they also have a joint component. Let's run this scenario. Biting on both, pain on the left. Biting on the left, pain on the right. Biting on the left, pain on the left. All right, we look at that. So we got left masseter pain, but right jaw pain. There's many variations of this. This is just to kind of get you an idea of how you'd use some sort of provocation testing to figure out where this might be coming from. But this can be a really saving grace in many instances to get an idea of what the patient may have. Bilateral temporal pain, more times than not, is probably due to clenching. What you got is myalgia that's taking place, typically described as a dull, aching pain during function of affected muscles. When I open, it hurts. When I chew, it hurts. But when my jaw is at rest, it doesn't really make a difference. It doesn't really hurt. Great, you fit in the criteria. You palpate the area, there's tenderness associated with it. Now with myalgia, when you palpate them, you're not going to have pain that refers elsewhere. In other words, where I push it is where the pain is. That's myalgia. The descriptive terms that patients use many times, the pains of a dull, aching, and continuous in nature, and it's basically confirmed by doing your examination in regards to it. Treatment for it would be physical medicine, moist heat applications, passive stretching with moist heat. You could use medications such as muscle relaxants to take into consideration, but there again, shortly used, not long-term use. All right, Symptomatic relief, there again, moist heat, muscle relaxants, in some cases, NSAIDs. If you are comfortable using topical medications, which is my preference with these patients, the advantage of topical, I don't get a systemic effect with the muscle relaxants. Remember, they're already apneic. And then you put them on a muscle relaxant, which is going to make the airway even worse. So what I'd rather do is put them on something that's topical to affect the area of concern and leave it at that. All right, pain in the jaw, use NSAIDs, use steroids, maybe discontinuing the appliance for a period of time and then revert back to it once things have improved. And there's no harm in using a physical therapist. I mean, if you've done everything and you still can't get the pain under control, use a physical therapist. With their physical modalities, they'll be able to revert if it's muscular and or joint-based pain. But what you'll find is most clenchers will have bilateral temporal pain. And one way to kind of minimize that is just to add a discluding element to the appliance that you use. For example, on the left, you've got a dorsal with a discluding element, so none of the posterior aspect of the devices make contact. So when they clench, they're not able to generate significant force. And on the right, you've got the true function herps, once again with a discluding element, same rationale, preventing the posterior aspects from actually touching. These two can be a quick fix, and for many times you can do chairside, or going into your case, if you know that this might happen because they have a significant history of clenching, then just have the lab add the discluding element. It's easier to cut it off than it is to actually add in some cases. Limited range of motion. They were doing great, wore your appliance, and now they can't open as wide. What happened? All right, let's look at this. Could be myospasm. Maybe there's a muscle that's in spasm. The most common ones possibly will be the lateral pterygoid. Okay, but in some cases you'll also have maybe the masseter. Very rare you'll have the medial pterygoid. As a result, you'll have reduced range of motion, pain is aggravated by function, and the patient feels like it's a tightening or a cramping-like feeling in this general area. But another reason for limited opening can just be the fact that they may have had a healthy joint that used to click, and now they wake up the next morning and they're not clicking anymore. So now they have disc displacement without reduction. One of the aspects associated with it is definitely limited opening, along with all the other things that we talked earlier. So these are things you want to keep in the back of your mind when you have a situation with limited opening specifically. And if you look at this situation right here, day of delivery, teeth are touching, January 2009. July 2009, now we have a bilateral posterior open bite. This is probably what you see more often. The reason for that many times is shortening of the lateral pterygoid. As the shortening of the lateral pterygoid takes place, the condyle seats more anteriorly. When the condyle seats more anteriorly, you get posterior bilateral open bite. The reason for that shortening is more than likely in your history, they're not following through with their morning regimen. In other words, whatever you may have asked them to do in the mornings to lengthen or to actually release the lateral pterygoids from its activity for the 6 to 8 hours while they were wearing the device, it not being performed can lead into what you just seen as far as an image is concerned. And if you look at that same case, there are a few things you can do chairside as well as have the patient do at home to try and get the pterygoid muscles to release so that they can get their bite together. It's a difficult process to explain on a webinar, but what I want you to understand that it can be done where you can regain some of this lost position in some of those individuals. Hopefully you see a synopsis of what this looks like in clinical practice. What you also hopefully will have gotten out of this is some key pearls. But I think my emphasis would be, look, treating the airway is extremely easy if you can respect and understand the temporalmandibular joint. So if you feel that maybe your understanding of the joint is somewhat limited, I strongly encourage you to consider taking some courses to try and get to the point of understanding it, because if you can understand the jaw and some of the nuances associated with it, you can pretty much prevent a lot of these issues from actually occurring. I think I've taken more time than I should, but I'm hoping that you've got enough information to walk away with and challenge yourself in all fairness. And if you have a situation that arises based on what we discussed here, then maybe you've had some answers and solutions now that you can start applying and see how your outcomes come. Thank you for attending.
Thank you so much, Dr. Patel. Before we jump into the question and answer session, the Vice President of Neerman Practice Management, John Neerman's just going to say a few words here about some upcoming seminars for those of you that are looking for more education in TMD, dental sleep medicine, a little bit of both, or cross-coding for medical billing and dentistry. We've got some excellent seminars coming up this way. So as soon as we get through that, we'll jump over to the questions. So over to you, John.
Well, thank you, Courtney. And thank you again, Dr. Patel. Just such a wealth of knowledge. It impressed me every single time you speak. And I know we have a lot of familiar names on the webinar. So great to see everybody on. And I just wanted to touch base with everyone and let everyone know what's going on with our courses coming up for the rest of the year and where you can see Dr. Patel learn more about TMD, dental sleep medicine, and cross-coding, like Courtney said. So this coming weekend, probably too short notice for most people, but there's still a couple days before our Dental Sleep and Pain and Dental Writer Conference in Fort Lauderdale, and that's coming up this Friday and Saturday, October 25th and 26th. So that's going to be a lot of fun. We have a great lineup of speakers on the sleep and pain side, including Dr. Gary Demerjian and Dr. Patel. Speaking of Dental Writer, for those of you who are looking for a system to help streamline your process for getting your ducks in a row with dental sleep medicine, TMD, with those questionnaires, the exams, and generating all of your documentation, your SOAP reports, your medical claims, and streamlining all of your communication and your letters with physicians and insurance companies, that's what Dental Writer is for. It's an amazing tool and resource for implementation. And so if you are not currently utilizing Dental Writer, you just reach out to us, let us know. We'd love to schedule a demo. And we also have an amazing medical billing service too that synergizes really well with Dental Writer. And so for those of you who didn't know about that, we have a great medical billing service as well. So on to the courses. So where can you see Dr. Patel next? We have our orofacial pain, our next orofacial pain mini residency coming up actually the week after our user conference. So November 1st through the 3rd coming up very soon. And that's our winter retreat orofacial pain mini residency with Dr. Patel and Dr. Terry Bennett, two mentors in sleep and pain. And that's a 2-session program. And actually, I think there's some people on this webinar that are coming to that program. And but again, this one is pretty short notice coming up next week. So if you can't make this one, we do have another class scheduled next year starting in July 24th through 26th, and session 2 in September 25th through the 27th. So that's a really comprehensive pain program that we've done several times, and it's just a really great program. And for those of you who are interested in learning more on this subject today of what we covered, we have our full 2-day TMJ for the dental sleep medicine practice and PRP injections. We're bringing on a guest speaker, Dr. Brajesh Chandwani, to introduce our PRP injections for TMJ. So that's going to be a very interesting program. Plus, we have Dr. Patel going through pretty much 2 full days, a day and a half of this same content of TMJ for sleep. So that's going to be February 21st and 22nd in Atlanta. Another really great program. So that's where you can learn more on this exact topic. And coming up in April, we have our appliance course for dental sleep medicine in TMD. So this is 2 full days where we do a deep dive into the pros and cons of all the different appliance types, the mechanics behind sleep appliances and the various TMD appliances, as well as there's a whole examination and workflow aspect and communicating with your dental labs to get the best outcomes. We even do some hands-on bite registrations, hands-on exam workflows, and troubleshooting. So this is a really great hands-on course that we're doing in Atlanta in Dr. Patel's practice. I love the courses that we do there because of the operatories, and we limit all of those courses to only 23 participants too. So it's a really personalized experience. So, and last but not least, we have our cross-coding, Unlocking the Code to Medical Billing course. And we do these next to most of our clinical courses. So you can find one of these cross-coding courses next door simultaneously. And this is taught by Rose Neerman, who is founder and CEO, and my mother of Neerman Practice Management. And she's the mother of me and Neerman Practice Management. So this is such a great program for learning, for sending not only your team, but we have dentists and the doctors come to this program too. And they find it extremely valuable for themselves as well, because we'll teach you start to finish how to bill for sleep apnea appliances, TMJ appliances, oral surgeries, frenectomies, different laser procedures, and we're seeing some pediatric airway policies are starting to come out as well. So all the different tips and tricks and strategies for how to successfully implement medical billing and how to get your ducks in a row. So, the next one we have is December, but like I said, we have them next door to all of our clinical courses. So you can send your team to learn how to bill while you're learning the clinical aspects on the other side. So it works out really well. And that's our whole philosophy at Neerman Practice Management, is get the whole team involved. And send the assistants and the hygienists to the sleep courses that we have, and the dentist for the TMJ courses, and the front office for the cross-coding courses. And that's what's going to be the key to really growing these areas, is getting the whole team involved and educated. So thank you for that. And let's move on to Q&A. Oh, and we do have a couple specials. So if you are interested in one of these programs coming up, we have a special that ends at the end of October, and it's specifically for the cross-coding course. But if you are able to come to one of these courses, just send me an email, and I'll let you know of the different specials that we have. All right. Cool.
Great, thank you, John. We'll run through just a few of the Q&A questions here. I know it's getting late for you East Coasters, so we'll run through just as many as possible. And if we are unable to get to your question this evening, we'll certainly follow up with you via email for the email you used when you registered. So just real quick, first off, we've had a couple questions on if a recording is going to be available. If you are a current dental writer user with an active maintenance and support subscription, great news is we do record all of these sessions for our clients, and they will be available right in the Dental Writer Help Center starting tomorrow. For those of you that are joining us as non-clients, you will receive a follow-up email with a link to view the recording of this session, as long as you were in attendance this evening. So just a few questions here for Dr. Patel. Well, first, one comment. Dr. Viet let you know that this is a great refresher presentation, so thank you, Doctor. And now a couple of clinical questions for you here, Dr. Patel. The first one from Dr. Snell. If the midline is off, how do you correct that, or do you remake the appliance?
Good question, Brandon. So typically, if your midline's off, you can chairside correct it. In other words, if you had like a herpes or a dorsal, and let's make the assumption that the jaw is off to the right, and you need to centrate back up, then on the right side of the herpes or the right side of the dorsal, you can advance the fin or advance the screw to align the midlines. If you have like an EMA type appliance, then what you may do is they come with 21 straps. You may need to take a shorter strap to kick the jaw to the opposite side, and there'll be a mismatch in numbers, but you can still make that correction chairside. So depending on the type of device, a lot of this can be done chairside, but if it's significantly off, where it's going to take a series of millimeters to correct it, then you definitely need to send it back to lab with a new bite and have them remount it, reset it for you.
Wonderful. Thank you, Dr. Patel. The next question we have here is from Sandra. First of all, thank you, Dr. Patel, for a very informative presentation. Can you comment on pre-treatment considerations for the use of bruxism appliances, aka night guards? For example, screening for OSA prior to prescribing and the effects they can have on undiagnosed sleep apnea.
Sandra, this is like one of those questions that is going to upset a lot of us because we never look at it from the perspective as you are asking, but it's a very, very important and valid question, especially in today's world, especially from the standpoint that we now understand that when we stuff things in people's mouths, we can affect the airway for the positive or for the negative, and more times than not, possibly for the negative. So there's many papers published about increasing vertical, which basically happens with a night guard of some sort, and the impact on the airway. I guess the question would be is, do you get this patient screened first for an airway issue besides proceeding with the night guard? And I would say the answer is your clinical exam. For example, large Malapati score of 3 or 4 increases the risk of having apnea. Lateral tongue scalping, 82% of those patients have apnea. Comorbidities, if they have hypertension, diabetes, or a history of stroke or TIA, you already know, therefore, there's probably an underlying issue that's taking place. BMI over 30, and you could use also something called a stop-bang questionnaire to kind of get a sense of how much risk is there in this individual of them having an unstable airway that's not being assessed. And that would be the way to go before you stick them with the device. But yes, very important question. It's not a matter of just putting plastic in there. It's the matter of understanding that by putting the plastic, we just don't want to make the airway worse. So we got to be very, very cautious. You may have had experiences with patients where you fit them with a night guard and they happen to contact you and say that the next morning it's in the bed or it's on the floor, it's not in my mouth. That itself is a clue that you might have obstructed the airway, and as probably a natural reflex, they withdrew it because they were suffocating. So, proceed with caution, but definitely look at clinical indicators for airway issues and start from that perspective.
Great, thank you. I think we can sneak in one last one here. I know we're a few minutes past the hour here. Dr. Patel, for a person just starting in sleep medicine, what education is a good pathway for being competent?
So the best way to answer that is you want to start from foundation all the way to a good hands-on approach. So we do offer a 4-part sleep mini residency that's pretty much didactic and hands-on based. Well, we start with the understanding of the science of sleep, which is basically lectured by a medical professional, followed by the things that a dentist should do from a screening perspective, leading into taking bites on each other, picking devices for your next delivery, which happens at session number 2, where you actually fit devices on each other. And we leave errors. In other words, when you took your bite, if we saw that you made a mistake, we let the mistake pass. And the reason we make it pass is when the device comes, we then talk about troubleshooting chairside to correct whatever may have happened as a result of the bite. So when you have a handful of students, you're always going to run into issues, but it's a good learning experience. We then go into dealing with complications and side effects associated with oral appliance therapy, how to get better outcomes with oral appliances, and trying to mitigate some of the long-term issues that occur with appliance therapy. We bring in the discussion of a pediatric airway as far as how to screen for it and how to manage it. But more importantly, also, we bring in an ENT discussing the nasal passages because the nose is extremely critical when it comes to understanding airway issues. So I would suggest if you wanted to truly be proficient, then take a sequential path of education rather than tailor or piecemealing it with a course here, a course there. And hopefully that will give you the confidence and the support that you need.
Yes, and that our next dental sleep mini residency begins April 17th and 18th in Atlanta. And as Dr. Patel said, it's a 4-session program, very comprehensive with many, is a multidisciplinary faculty for this program. Really great program. Oh, and I had one more, I had a quick correction on that appliance course. This one we're actually doing in San Diego not Atlanta. So we had a lot of requests for a West Coast appliance course. So this one we are bringing to San Diego for the next one in April. So West Coast and East Coast, a lot of programs.
Okay, great. Thank you again, everybody. Dr. Patel, thank you so much for taking the time. As always, we're getting lots of thank yous here in our chat box and Q&A box. So looks like everybody really enjoyed the session. If we did not get to your questions this evening, you know, feel free to shoot us an email to contact us at dentalwriter.com, and we'd be happy to get those answers over to, questions over to Dr. Patel. But thank you again, everyone, so much for joining us this evening, and we hope to see you at an upcoming seminar.
Thank you all.
Thank you, guys.
Thank you, everybody.
Have a great evening. We'll see you next time.